Welcome back to PedScript. I'm Zach Hodges, a pediatric intensivist at the University of Texas Southwestern in Dallas.
And I'm Mal Shanklin, a pediatric intensivist at Cohen Children's Medical Center in New York.
And we are so excited to be sitting down again today with Dr. Nicole Glaser to discuss hyperosmolar DKA. Listeners, you will hopefully see in your feed, we've interviewed her previously on DKA management. We're leaning in today, taking it a step further. Dr. Glaser, will you please remind everyone who you are and what you do?
Okay, sure, yeah. Well, I'm a pediatric endocrinologist and researcher at University of California at Davis. I have a long-standing interest in pediatric DKA, and I've done both clinical and basic science work in that area, along with several multi-center collaborations. And I've also had the pleasure of working with international colleagues on several pediatric DKA guidelines, including one we're working on right now for the International Society for Pediatric and Adolescent Diabetes, or ISPAD. The revised version is supposed to come out in 2026, so that's ongoing at the moment.
Oh, wonderful. Well, definitely something for us to look out for on the PICU side. Dr. Glaser, I suspect the answer is no, but do you have any conflicts of interest to disclose related to today's topic?
No conflicts.
Wonderful. Let's go ahead and jump in with the case. So we have a 15-year-old male. He has a known history of type 1 diabetes. He presents with ultramental status, polyuria, polydipsia, the typical syndrome of DKA. We suspect he hasn't had any insulin for a couple of days. His initial labs showed a glucose of 800, pH is 6.9, ketones are positive in the urine, serum sodium is elevated at 155. Physical exam, dehydration, of course, so there's decreased skin turgor, prolonged capillary refill time. His mental status is altered, so he is opening his eyes and localizing to pain, but not following commands, only vocalizing incomprehensibly. Already received 120 ml per kilo saline bolus. So listeners who take care of patients in the pediatric ICU will be familiar with DKA. You have hyperglycemia, ketoacidosis, but topic of today is hyperosmolar DKA. So leaning into that, how is hyperosmolar DKA defined, and how is it different than just severe DKA, and how is it different than hyperglycemic hyperosmolar state?
Okay, well, children with hyperosmolar DKA meet the criteria for DKA, but they also have the hyperosmolar state that's characteristic of HHS, or hyperglycemic hyperosmolar syndrome. So in HHS, children don't have significant ketosis and acidosis, but have severely elevated glucose levels and hyperosmolarity. So HHS is defined by glucose level above 600. Typically, as I'm sure you've seen, also far higher than that. These are the children that sometimes have glucose levels like above 1,000 and osmolarity above 320. In hyperosmolar DKA, children have that same severe hyperglycemia and hyperosmolarity as in HHS, but they also have the significant ketosis and acidosis like we see in DKA.
And we take care of DKA every day in the PICU, and it's one of those so familiar diagnoses that, we expect the kid to come in and then we rehydrate them overnight and get them eating in the next morning and they're out the door. But should we think of that patient with hyperosmolar DKA in the same way, or is there something a bit more sinister about this diagnosis? Is it higher risk for complications?
Yeah, so that's a great question and an important way to think about it, because DKA is a very protocol-driven kind of a thing that, most sort of garden variety DKA generally does pretty well on the standard protocol. But these are the kids that are likely to not do well on the standard protocol. They really do need quite a few changes in what we typically do for DKA. And I think that's often the biggest mistake in taking care of these kids, is that they do get sort of started on the regular DKA protocol. And it's not until sometime down the line that people notice that they actually need something a little different or are developing complications.
Interesting. Every PICU fellow gets like hundreds and hundreds of transport calls for DKA during their fellowship. Would it be accurate to say that every time you get a DKA transport call and the glucose is above 600, you need to mentally pivot the patient from a classic DKA treatment pathway to an hyperosmolar DKA treatment pathway?
Well, that's an important point. And not everyone who has a glucose above 600 necessarily has hyperosmolar DKA. It really depends on the osmolality. So, you can have a glucose above 600, but have a pretty low sodium level and not really be very hyperosmolar, in which case we wouldn't have these same worries. But like in this patient's scenario, if you calculate the corrected sodium for him, the corrected sodium is 166, so, quite high. So definitely would qualify as hyperosmolar, and you'd have more of that concern. So I think you have to look at both the glucose and the sodium to decide how much you're worried about hyperosmolar DKA.
So let's give you the fog of this patient not being your institution. Alice and I get so many phone calls, and I'm sure you do as well, for these transports. They're describing a child for you. Perhaps you're on the call. We got endocrine involved, which is always wonderful.
Loop them right in.
Yes. We're describing this child with altered mental status. We even had the labs back, which is great. And it seems like there's evidence that he is hyperosmolar. They've only given 120 per kilo bolus. Perhaps they've even expressed that they're worried about giving too much fluid. How would you guide the resuscitation at this point?
Yeah. So since we know he's hyperosmolar, and most children with hyperosmolar DKA will need much higher rates of fluid resuscitation than what's typically given in DKA, and the fluid resuscitation does need to be more similar to what a typical patient with HHS would need. So for comparison purposes, like the typical child with DKA has about 7% dehydration, so about 7% of body weight on average. A typical child with HHS has like 12 to 15% dehydration, which is about double. So, for the patient in this scenario, a 20 per kilo bolus is almost certainly insufficient. I would assume he would need at least 2 boluses of that, volume, maybe even more. And then typically ongoing rates of fluid resuscitation need to be higher too. So probably at least 1.5 or maybe twice what we would usually do for DKA. The other difference fluid-wise is that, we don't typically recommend replacing urine output in someone with DKA. But in someone with hyperosmolar DKA, especially if they're presenting with like a glucose that's really high, 900, 1,000, something like that, it's going to take a really long time for the glucose level to drop to the point where they're not having osmotic diuresis anymore. So the urine output is going to continue to be brisk for a much longer period of time. So these are patients where also that needs to be considered. Not necessarily that it always needs to be done, but looking at urine output and making sure that the fluid balance is gradually positive is really important, because they can continue to have really brisk urine output for quite a while.
So if we're thinking about all of our DKA patients, and this case is a known type 1 diabetic, and he's presenting with hyperosmolar DKA, and we say that the hyperosmolar patients are more dehydrated, can you explain the pathophysiology here? Why are some type 1 diabetics coming in hyperosmolar DKA?
I don't think that that's necessarily very well understood. There's a really wide variation in how DKA patients present. The other end of the spectrum is like what we call euglycemic DKA, where they either have near normal or normal glucose levels. There's some studies quite a long time ago, where they looked at what was going on in the days preceding presentation to the hospital. And there's some evidence to suggest that whether they present with really high glucose or low glucose sort of depends in part on intake of carbohydrate and sugar during the period of time leading up to coming to the hospital. If they're still drinking pretty well and tending to drink things that are high carbohydrate, like soda or juice or something, which hopefully is not the case in this kiddo's case because he has known diabetes, or, on the other end of the spectrum, if they've been vomiting and ill for days and unable to take much NPO, then glucose levels might tend to be lower. But outside of that, there isn't really great information to explain why someone would come in this situation versus ordinary presentation of DKA.
Oh, interesting. So it's not known, but it could be kind of related to like rehydrating with water, rehydrating with pure apple juice, or not being able to hydrate at all.
Yes. Yeah.
Type of thing. Okay.
This question came across my mind as we were chatting. One thing that I was taught to me in residency, whether this is true or not, is that diabetes is not as clean as type 1 versus type 2. Like there's significant overlap. Do you find that there's a degree of insulin resistance that's required for patients to develop hyperosmolar DKA or HHS?
That's a really good question. I'd love to see a study of that, actually. Maybe have a fellow who would like to take that on. But Certainly we see HHS more frequently in type 2 diabetes, and some children with type 1 diabetes have level of insulin resistance. Often they have family history of type 2 and other relatives and things like that, although they have type 1, and tend to have some aspects of type 2 diabetes. But generally, the link between type 2 diabetes and tendency to develop HHS is thought to be related to the fact that they still do make a little bit of insulin. And so the amount of insulin you need to suppress ketosis is less than what you need to manage, glucose levels. And so it's easier for them to develop HHS because they have this ongoing hyperglycemia, but don't develop the ketosis that typically brings someone into the hospital because they're sick and vomiting and look seriously ill. So, that's the connection there. But if you have type 1 and have some of the genetic, kind of underpinnings of insulin resistance in type 2, that situation probably wouldn't happen because your insulin production still is, very low. But it would be very interesting to look at some of the, epidemiological characteristics and other of children who develop hyperosmolar DKA versus just the garden variety.
Yeah, that's great. On our prior episode, we talked about how the level of illness can be one of the influencing factors on whether kids develop cerebral edema associated with their DKA episodes. And when I think about children with hyperosmolar DKA, these are probably our sickest kids with DKA. So the question is, do we know what the incidence of clinically significant cerebral edema is in children with hyperosmolar DKA? And since our main treatment for cerebral edema is additional hyperosmolar therapy, that seems incredibly complicated.
Yes, indeed. And I think that is one of the most difficult challenges in these patients because they do tend to have high rates of mental status alterations at presentation. But I don't know of any studies that have directly documented rates of cerebral edema in hyperosmolar DKA versus ordinary DKA. But what I can tell you is that in studies looking at risk factors for cerebral edema in children with DKA, the level of hyperglycemia at presentation has not been associated with risk for cerebral edema, interestingly. And that's been found in multiple different studies that were controlled for severity, like for pH and things like that, for severity of DKA. And even in HHS, where we discussed, glucose levels can be exceedingly high, 900, 1,000, rates of cerebral edema are actually very low. There's only very few case reports of cerebral edema reported in HHS. And it's thought that the frequency in HHS is actually lower than in DKA. So with all that put together, my guess would be that the rate of cerebral edema in someone with hyperosmolar DKA is probably similar to anyone else with DKA. However, there's the challenge of the mental status alterations that, people, adults and children with HHS very frequently have altered mental status at presentation, which I've never read a great explanation for exactly why that occurs, but presumably it's related to the hyperosmolar state per se and altered cerebral perfusion and such that might go along with that. But it does create a tremendous challenge in trying to figure out in a patient like this, how worried do you need to be about cerebral injury, cerebral edema, versus just that altered mental status that goes along with being in hyperosmolar state.
One thought could be, and please refute this if this is incorrect or just not substantiated at all, if the serum osmolarity is so incredibly high, could that somehow be protective against developing significant cerebral edema?
Yeah, it does in a sense, because there's some data to suggest that cerebral edema actually develops because of brain hypoperfusion, reperfusion. But if you've got a super high osmolality, your intravascular volume is relatively preserved, which is, of course, important part of the pathophysiology of HHS and why they can come in exceedingly dehydrated, but without symptoms up until, the day or two before they come in. So circulatory volume is relatively preserved in someone who's hyperosmolar. And maybe, that's part of the reason that they don't develop cerebral edema, because maybe they don't have, the extent of hypoperfusion and then the the tendency towards reperfusion injury we think might happen in DKA.
Oh, yeah. Because if the osms are pulling everything into the intravascular space, it's going to plump up the vessel more than you would expect for someone who's X% dehydrated.
Exactly.
How do you translate this into the treatment pathway for hyperosmolar DKA?
Yeah, so understanding that concept is probably one of the most important aspects of treating someone with hyperosmolar DKA, because when they come in, they are in that state where the circulatory volume is relatively preserved, but they're supremely dehydrated. The tissues are supremely dehydrated. And so what happens when you start treating them, treat them with insulin, for example, the glucose level is going to drop and the osmolarity is going to drop. And so the volume is going to move from the blood vessels out into the tissues and lead to circulatory volume contraction, which is, important difference between someone with hyperosmolar DKA and garden variety DKA is that they do need a lot more fluid replacement up front before the glucose level drops, because otherwise you can have, organ hypoperfusion or even shock developing in someone who's receiving IV fluids, but just not enough to compensate for the decline in circulatory volume.
So I've seen treatment pathways for managing HHS where you're commonly giving even hypotonic fluid, elevated fluid rates compared to DKA. In hyperosmolar DKA, would you commonly see yourself prescribing more hypotonic fluids or still staying with isotonic fluids like you would with a typical DKA protocol?
I'd probably stick to the typical DKA protocol and use, isotonic fluids, because generally in these patients, even isotonic fluids are still hypotonic compared to where they're at in terms of their osmolality at presentation. And then that can be reconsidered if, the sodium level is persisting very high many hours into treatment.
Yes. And then for that initial transport call, I'm hearing that if we give you this known type 1 diabetic, but his glucose is 800, it seems like hyperosmolar DKA. You're learning more about the labs. You're hearing the serum osmolality, the sodium. You're thinking, oh, this is hyperosmolar DKA. The outside hospital is asking if you should start insulin. And if they start that 0.1 unit per kilo per hour of insulin early without adequate fluid resuscitation, they'll drop the glucose, drop the osmolality, and then there won't be enough intravascular volume, and then you'll see shock.
Yeah, that's the concern. So you do really want to get a decent amount of hydration on board before starting insulin. And the patient in this scenario is one of the most difficult in terms of decision making about insulin, because he does have a really low pH, 6.9, so severe acidosis. So you do want to start reversing ketosis, fairly quickly, but, he's also hyperosmolar and has all those issues we just talked about. So probably, the best plan of action is to try to get some substantial amount of boluses on board, but then you would need to start insulin still fairly soon.
Got it. So I've seen some recommendations or even just institutional things where it's like, okay, well, now they have HHS. Instead of starting insulin, I'm going to wait until their glucose is below 600 or below some value, and then I'll transition to them to the normal DKA pathway. Do you use anything like that in your personal practice?
The insulin plan for these patients really needs to be very individualized. So, for example, if you had someone who was minimally acidotic, still had DKA, but minimal acidosis, but had a glucose of 900 or something like that, you probably would, or it would be reasonable, to wait to start insulin similar to what you would do in a patient with HHS, because they're not severely acidotic. You're not that worried about reversing ketosis as quickly as possible. In someone who's more severely acidotic, that's a tough one. You might start with fluid boluses and see how you're doing in terms of pH and things, and if that's improving, and the glucose will certainly come down with fluid boluses for sure. You can kind of play it by ear, but it's definitely one of those things that needs to be individualized for each patient.
So maybe leaning into that, thinking about our case, glucose of 800, he's hyperosmolar, his pH is 6.9. Talk to us about how you perhaps would start that insulin therapy, and perhaps what clinical factors would you monitor to titrate that therapy?
Yeah. So one thing that's super important is, monitoring circulatory status. So really frequent reassessments of fluid balance, of peripheral perfusion, heart rate, blood pressure, et cetera, to make sure that whatever's happening with the glucose, that you're maintaining adequate circulation and perfusion. Probably with this patient, if this were a transport call I was getting, the recommendation would probably be to give at least one more bolus of 20 per kilo, reassess how he's looking in terms of all those things we just talked about, possibly even give an additional bolus after that, and then maybe reassess glucose and pH at that point. If the pH seems to be improving just with fluids, you might even wait a little bit longer, start ongoing fluid replacement and then wait maybe a little bit longer to start insulin. If there's not substantial improvement in the acidosis, then I would probably go ahead and start right away, but while keeping a really careful eye on circulatory status and, increasing in fluid infusion rate if you need to.
Let me emphasize something just to make sure that I'm understanding correctly. So we have this patient, as they're presenting to care, they are incredibly dehydrated, but their intravascular volume is maintained just because of the high degree of hyperosmolarity. The pitfall here, as I understand, is if we give them insulin too early, their intravascular osmolarity is going to drop, and they're going to have lots of fluid move from the intravascular space, outside the intravascular space, and then they're going to develop shock in front of us. Is that the main reason that you would generally like to prioritize isotonic fluid replacement first, and then perhaps delay that initial insulin therapy until you have more information?
Exactly. Yeah, that's exactly right. That's the scenario that can develop where patients like this sometimes can really get into trouble.
The cornerstone of critical care is frequent reassessment, right? And one thing that really worries me is that we take transport calls from kids hundreds of miles away. They have DKA, the referring clinician, incredibly busy. And perhaps if our transport team can't pick up this child, we won't have a conversation about this child for potentially 3 or 4 hours. I just get so worried about making these prescriptions for recommendations for what to do without that reassessment. And I think, having this nuanced conversation of let's volume resuscitate, reevaluate, and have a clear plan for when to start insulin for these kids is so important.
Yeah, and that is really difficult if you don't have the patient right there in front of you. And I think just like you're saying, getting lots of details and talking to the outside hospital really frequently has got to be the key, because there isn't one specific pathway that's always going to work for these patients. There's really such a variety of the balance of how acidotic they are, how dehydrated they are, how high the glucose, and each one is a little bit of a different scenario.
Yeah. Now, understanding that it's going to be tailored to the patient in the clinical setting, and that the plan needs to be reevaluated if the patient's getting worse, hypotension, worsening tachycardia, worsening mental status. When you do start insulin, are you starting at that 0.1? Are you sometimes doing a 0.05, starting lower? And then we talked about in our DKA episode with you that monitoring the rate of glucose decrease is less of a big deal in classic DKA patients. But I'm curious if this changes in hyperosmolar DKA.
Yeah. So again, it sort of depends in these kids on the balance between how hyperosmolar are they and how acidotic are they. Again, in someone who is not that acidotic, maybe more moderate pH of 7.18 or 7.2, but very hyperosmolar, it would be reasonable to start at a lower dose of insulin, maybe 0.05 units per kilo per hour, like half, and then monitoring pH really carefully and level of ketosis, measuring beta hydroxybutyrate levels to see that it's decreasing still on that lower dose. For the patient in this scenario, he is really severely acidotic. So it's a tough call whether to use a lower dose or start at the standard dose. You could try a lower dose and see what's happening with the ketone levels and the pH, but then, move up to the standard dose pretty quickly if you're not seeing improvements there.
So maybe let's lift the veil, and this child is now at your institution. You have more opportunities to reevaluate them, get more information. So they've been resuscitated. Perhaps they got 50 per kilo of volume at the outside. They're on a good maintenance fluid infusion, maybe 2.5 times maintenance. They're making urine, but we're getting a steady positive fluid balance. We're on insulin infusion at 0.1. We're still seeing hyperglycemia, above 600. We're still hypernatremic in the 150s, but now we can control things. So we feel at least a little bit better about that. As an intensivist, I think about a child that gets sick over 2 or 3 days. I get really hesitant to fix that kid in 6 hours. So I get really hesitant to make that sodium 140 by tomorrow morning, get really hesitant to make that sugar 120 by the morning. Will you tell us more about the pace that we should expect these kids to improve, and perhaps which clinical variables are you monitoring to titrate your therapies?
Yeah. So again, it all comes down to thinking about what the glucose and sodium levels are doing in terms of circulatory volume. So you don't necessarily want the glucose and the sodium to snap back to normal very quickly, again, because of the issues with volume leaving the circulation and going out into the tissue. So for that reason, want to promote a gradual decline in glucose and sodium. In the past, we used to worry a lot more about dropping the glucose or the sodium too quickly because of risk of cerebral edema, but that has pretty much been debunked by studies showing that there isn't any association between fluid rate or fluid sodium content and risk of cerebral edema. So, for that reason, we probably don't need to worry about the decline in glucose or sodium. But in patients like this, we do need to worry, again, because of issues related to maintaining good circulatory volume and organ perfusion. So a gradual decline, the usual rates are kind of like glucose should drop by 50 to 100 or so per hour seems reasonable. I don't know that there's a real evidence base necessarily to support that specific number, but that's the one that's sort of been used. Typically at the beginning of treatment with rehydration, glucose levels do drop more quickly just because you're reperfusing the kidneys and they're doing what they're supposed to do and getting rid of excess glucose. So that's not something that should really be worried about. But generally speaking, kind of 50 to 100 per hour is reasonable. The other thing as far as monitoring with these kids that's really important is really frequent electrolyte monitoring, because typically with hyperosmolar DKA and certainly in HHS, electrolyte deficits also are far more extreme than they are in regular DKA. So they're much more at risk for severe hypokalemia. The other big one is hypophosphatemia, which actually has been linked to some complications like rhabdomyolysis and hemolytic anemia that can happen in patients like this.
Oh, wow.
Yeah. So not every DKA protocol has a lot of monitoring of phosphate levels, but in a patient like this, you would definitely want to include that, and probably just as frequently as monitoring of like potassium and others more standard electrolytes.
You thinking hourly or Q2 hours? Or
Probably Q2 hours, and then again, it sort of depends on the trajectory. If you're seeing a rapid drop or change in something, then you might go to hourly if you needed to, but I would certainly do every 2 hours in someone like this.
You've given me an opportunity to emphasize something that's my favorite thing to talk about. It's going to the bedside and reevaluating a patient.
invite yourself to the bedside? That's your thing?
It's so easy in DKA management to kind of fall into like, you're the chart checking doctor, where you're watching the hourly sugars, you're watching the electrolytes every hour or every 2 hours, something like that. I've already heard multiple times from you today, though, intravascular volume status and perfusion to the brain is the most important factor here, as it seems, to not get a terrible outcome like a neurologic injury. And we should be much more worried about that status of our patient, more so than did the sugar fall by 101 versus 99 in the last hour. Is that fairly stated?
Yes. Yeah. This is definitely a patient where you want to be at the bedside frequently to reassess perfusion, look at the vital signs again, look at mental status. Frequent reassessment is really key because these patients do need really individualized care.
You've already mentioned a complication I don't anticipate much with DKA, hemolytic anemia from hypophosphatemia. What are some other, perhaps less common complications that kids with hyperosmolar DKA might experience that we need to consider monitoring for?
Yeah, so these kids are at risk for a lot of the rare or, unusual complications of DKA that you read about in case reports. So Things like thromboses, ischemic intestinal necrosis has been described. Certainly,
Wow.
acute kidney injury, someone like this would be at higher risk for more severe acute kidney injury. AKI happens quite frequently in anyone with DKA, but someone who is presenting like this, more severe, and hyperosmolar DKA would be at risk for more severe AKI, even possibly renal failure. We already talked about severe electrolyte derangements that can happen, and sometimes it can be difficult to stay on top of the volume of, potassium and phosphate that they need. So there are quite a few complications. And again, it comes back to that same, frequent monitoring, noticing that there's a trend in something, the phosphate is declining, that the, creatinine seems to be rising when it should be falling, things like that is important.
The risk of thrombosis is something that I've even seen clinically, and we've even had like informal discussions about, do we start these kids on DVT prophylaxis, like chemical prophylaxis? And typically kids with type 1 diabetes and DKA, they spring back to action the next day. You really just nothing more than mechanical. Do you know if there's anyone that's published on, routine chemical thromboprophylaxis in kids with hyperosmolar DKA?
Probably not as a routine unless they had central lines. With central lines, it is generally recommended to at least consider that. So in kids with DKA or certainly hyperosmolar DKA, the rate of thrombosis of central lines is pretty high. Like there's some studies that even suggest like 50%. So probably worthwhile in that situation, if they needed a central line. Outside of that, it's not generally recommended as a routine, but it's certainly something to think about.
Oh, yeah. In your clinical experience with these severe hyperosmolar DKA patients, I imagine it's that the PIV doesn't always draw back. Zach, you feel like you usually end up lining these kids with an A line or a CVL?
Really uncommonly, honestly. Probably the arterial lines would happen if this were to present in a non-adolescent patient. Usually those, we can place some intracubital IVs. But if there's like worrisome mental status changes or, shifts where you're having malperfusion, would have a low threshold to place an arterial line in them. Uncommonly place central lines in these kids. I mean, the thrombosis risk is one. Of course, no one goes down without a central line, right? So if we needed to resuscitate them, we would do it, but would generally try to resuscitate them what we have available, if at all possible.
Yeah, that makes sense. And that's sort of the DKA patient thing, is if they wouldn't notice you putting in an arterial line with full cellular technique, then you might want to consider that. But otherwise, yeah. My other question is, I think one of you mentioned maybe a fluid rate of 2.5 times maintenance or pretty high fluid rate. I'm wondering how we got to that number and if that's standard clinical practice to sort of say, okay, you've given a couple boluses. I'm going to need you to crank that up to 300 mLs per hour, a really high fluid rate continuously.
Again, I think it's a matter of looking at all of the variables, looking at the vital signs and perfusion and the fluid balance to decide how high you need to go. I think it's important to recognize that, again, compared to like a typical DKA patient that's about 7% dehydrated, that someone like this is probably more like 10, 12, even higher percentage dehydration. So I'd probably go through the calculations, assume 12% dehydration, calculate how much volume that would be, and base your rate on that.
I love it. Just another example of, let's not put this child on the protocol, so to speak. Like, let's think about this one.
Visualize care.
Let's visualize this care. Let's reevaluate the patient after we made our initial prescriptions.
I have another question. So, okay, and now we're thinking about, so that's our starting fluid rate, and then we're monitoring things. We're monitoring, most importantly, the mental status and how the patient looks, but also how fast the glucose is dropping, how fast the pH is changing. What does a patient need to do to earn themselves a Foley and a 1-to-1 urine output replacement?
Yeah, I think that's really going to depend on the fluid balance. If you're seeing that you have a nice high rate of fluid infusion, but still urine output is so brisk that it's hard to keep on top of making sure that they're making nice positive gains in fluid balance during treatment. If you see that that's happening, then it's probably a good idea to replace urine output.
And maybe to round off our discussion of complications of hyperosmolar DKA, In preparing for today's talk, I even read that perhaps malignant hyperthermia is associated with hyperosmolar DKA. Will you just tell me, generally speaking, what is known about this? This seems quite bizarre.
Yeah, it's a really unusual complication. It's mainly been described in HHS, but can happen in hyperosmolar DKA as well. There's not really a lot to tell about it because it's not understood why it happens at all, but it does seem to be something that's unique to the hyperosmolar state because we don't see it in more standard, straightforward DKA.
We mentioned a couple times that these patients are sicker than the typical DKA patients and that there is actually a mortality associated with this that's maybe less related to the classic cerebral edema herniation pathway. How are patients dying if they die of hyperosmolar DKA?
Yeah, so case reports that I've read have mainly been, again, related to the issues with shock and circulatory volume. So where, maybe they were treated initially with just the standard DKA protocol, the fluid volume really wasn't enough, and they developed shock and renal failure and other organ injuries on that basis. I think that's been the most frequent scenario that I think I've read. Otherwise, there can also be some pretty severe electrolyte abnormalities and, cardiac arrhythmias because of rapid drops in potassium or phosphate. We talked about rhabdomyolysis, hemolytic anemia, and other things that can happen with extremely low phosphate levels. So those also, potentially could be severe complications.
You've already mentioned for us a couple of major pitfalls could be inadequate volume resuscitation early on, and then not aggressively repleting electrolytes as needed throughout the resuscitation. Any other major pitfalls that you'd like to highlight here in the management of hyperosmolar DKA?
I think those are the main ones, really. I think just the recognition is the most important part. I think once you realize that this person has hyperosmolar DKA, that it does need to be treated differently than the usual DKA protocol, that's, more than half the battle. And then at that point, making sure that they're getting the vigorous fluid resuscitation and very frequent monitoring and replacement of electrolytes at a much more brisk pace than would be typical is really the key.
And then kind of reflecting on your experience, do you know if any other perhaps common mistakes or medical legal considerations that we should be mindful of here in taking care of these extremely sick patients?
Yeah, well, from time to time, I do get cases sent to me to review because of concerns about medical malpractice. And I will say that the most common thread in all of those is almost always just what we just talked about, that it wasn't really recognized that the patient had something different from garden variety DKA, and that when you look back, of course, hindsight is always 20/20, but when you look back at what was happening with fluid balance during treatment, that the patient wasn't really having a nice positive fluid balance. They were maybe staying neutral or even becoming more dehydrated because they had very high urine output, and that wasn't noted or addressed or things like that. So I think just recognizing that this is different, recognizing what you need to monitor, and being there, doing the frequent monitoring and catching the trends before they become really extreme is important.
Oh, well, that's wonderful. Dr. Nicole Glaser, thank you so much for joining us today. This has been a fabulous conversation of a really important topic. Is there anything else that you'd like to discuss or reinforce before we wrap things up?
No, I think we've really covered the important points, and happy to talk with you both again today.